Good evening. Welcome to our monthly lecture series for PUYA, Professional Organization of Iranian Americans in Atlanta. Tonight, we are honored to have an eminent professor and a cardiothoracic surgeon, for which I'm grateful to Dr. Modarresi and Dr. Mahmoud Daneshmand, who introduced this great surgeon and scholar to me. PUYA is an affiliate of Qanun, and it's a non-religious, non-political, and purely an independent organization which predominantly invites scholars in different sciences to give us a wide spectrum of different sciences in addition to human sciences and cultural issues regarding our country. به معرفی مختصری از آقای دکتر دانشمند می‌پردازم. Dr. Mani Daneshmand is Associate Professor of Surgery in the Division of Cardiothoracic Surgery of the Department of Surgery at Emory University School of Medicine. Dr. Daneshmand serves as Director of the Emory Heart and Lung Transplantation and Mechanical Circulatory Support Program, and as Director of the Emory ECMO extracorporeal membrane oxygenation program, a board-certified cardiothoracic surgeon. His interests include minimally invasive cardiac surgery, cardiac and pulmonary transplantation, and mechanical circulatory support and extracorporeal membrane oxygenation. Dr. Daneshmand received his medical degree from Albany Medical College in Albany, New York. He then completed his surgical residency, cardiothoracic surgery fellowship and cardiothoracic surgery research fellowship at Duke University Medical Center in Durham, North Carolina. Dr. Daneshmand's research interests focus on the causes of and treatments for advanced heart and lung failure to identify new therapies for these diseases. These include new medications, such treatments as extracorporeal membrane oxygenation, ECMO, a device is similar to the heart-lung bypass machine that provides advanced life support to patients with lung and or heart complications, mechanical pumps such as ventricular assist devices that can stand alone or act as a bridge to heart transplant and organ transplantation for patients suffering from end-stage organ failure. Dr. Daneshmand, it's an honor for us. It is indeed an honor for us at Qanun Farhangi Iranian Atlanta and PUYA to have you as a speaker. And on behalf of PUYA and Qanun, I thank you so much, and we are all ears. Can you please start?
خیلی ممنون. Thank you very much برای این معرفی خیلی محترمانه. خیلی لطف کردین واقعا. I will switch to English for the presentation, and let me share my screen. So I was asked to speak on a very small topic, something that we will very easily cover with 50 minutes of lecture and 50 minutes of questioning. I expect everybody at the end of the conversation to be board certified and able to start their practice shortly thereafter this. So please forgive me at the lightning speed at which I think we may have to go through some of these topics, but I'm going to try to provide a very cursory background and information for both heart failure and lung failure, which on the surface seem to be very disparate fields and disparate problems, but ultimately actually a lot of their therapies come together and are worked together closely. These are my disclosures for this talk. And I think Some people on this conference today may remember this magazine and this article. This, of course, was in December of 1967, that fateful day when Christian Barnard identified a donor in South Africa. This was this young lady here. She was involved in a motor vehicle collision, and it had resulted in her death. And he had a patient in the hospital and was able to remove the heart from this young lady and transfer it into his patient and do the transplant. But why? Why do people need that? Well, when we're talking about heart failure, oftentimes we're talking about congestive heart failure. Congestive heart failure, what does that mean? Essentially, it's a scenario where the heart, which is nothing more than two pumps working in parallel and in series, start to be dysfunctional, and they work less and less efficiently. And as they do that, there's buildup of fluid in various areas of the body related to what parts of the heart are specifically failing. And so this is congestive heart failure is a large disease. It's a continuum of multiple different diseases with lots of different underlying causes. But the ultimate phenotype that winds up happening is the same thing. And we can classify it, and the most severe classification of congestive heart failure warrants organ replacement, either with heart transplant or other strategies that we'll talk about today. So how do we classify heart failure? Well, heart failure can be classified in four stages, A, B, C, and D. Stage A heart failure is really somebody who is at risk for heart failure, but maybe doesn't yet have symptoms of heart failure and doesn't have a structural problem with their heart. That may, for example, it may be somebody with diabetes who has some minor elements of coronary artery disease, but has not yet had a significant enough heart attack to cause abnormal function or abnormal squeeze of their heart. Stage B is the next step, and it's somebody who has developed some kind of abnormal function of the heart. Maybe there's a problem with one of the valves. Maybe the heart is not pumping as efficiently, but it's not bad enough for them to really have any signs or symptoms of heart failure. And we'll talk about what those are. Stage C is when people now start having symptoms or have had symptoms, but have been able to be treated and they go away. And then stage D heart failure is advanced and significant heart failure. So how do we classify people with stage D heart failure? Well, the New York Heart Association classifies these people with stage D heart failure 1 through 4, and it has everything to do with the ability to do activity. The first question is can the heart provide enough blood flow to keep you alive and have enough of a reserve in function to be able to increase that blood flow when you're straining it? So someone who's in NYHA class 1 heart failure has a problem with their heart. Their heart is abnormal, but they really have no significant limits in their activities of ordinary physical activity. So they can walk, they can take care of themselves, they can go up a flight of stairs, they're doing all that fine. Okay. Class 2 patients are starting to have some mild symptoms during regular activity. So maybe they're trying to walk up a flight of stairs, and at the top of the stairs, they're a little bit short of breath, or they have to take a break halfway up, or they have to take the stairs slower. Or maybe if they're walking on flat ground, they can't walk as far as they used to be able to before they get tired. And it's a kind of whole body fatigue. This then progresses to class 3, and that really starts to significantly limit their activity. So they have significant symptoms with any normal activity, brushing their teeth, eating, walking at all. And really, they're only comfortable at rest. And finally, stage 4 are people who cannot do anything. They're even symptomatic even when they're at rest. They're short of breath, they're they're unable to have rest. They feel constantly fatigued. And those are the sickest of the sick. And so, what do we do? So people who are, stage 1, may get tired a little bit with activity, but for the most part, they don't have significant problems. And so they can be oftentimes managed with just diet and exercise. As you progress to stage 2, your symptoms are a little bit worse, and you need more advanced, maybe medication to decrease your blood pressure, maybe some medication to try to decrease how much fluid is in your body, to try to improve the efficiency of the heart. As you progress to stage 3, you start needing significant, more stricter diet. You need a significant closer monitoring of your fluid status. If you have a particularly salty meal, or if you get particularly strained, you may wind up in a situation that we call decompensated heart failure. And so every day you're monitoring things and potentially in communication with your healthcare team to be able to modify medications as needed. A lot of those patients oftentimes actually learn how to manage and titrate their medications and get to a nice homeostatic situation. And finally, those in stage 4 heart failure are the sickest of the sick. And, their options include, again, heavier medications, stronger medications, but then we start thinking about them as candidates for surgical options, heart transplant, or other things. And if they're not candidates for surgical options, really the only thing we can talk about for them is palliative care. And you may say, okay, well, palliative care, that's kind of extreme, but we'll talk about what kind of life expectancy people with class 4 heart failure really have. So what is in our armamentarium for these stage D patients? Well, we have medications that try to optimize the heart function in a mild way. Those who fail that, we start using medications like inotropes, which make the heart beat harder. They are a double-edged sword, because while in the short term they make these patients feel better, they actually accelerate the rate of heart failure and potentially death. And so you're trading some life for some quality of life. Then we get into the surgical options. VAD stands for ventricular assist device, and we'll go into detail about how VADs were developed and what they do and what they don't do, and then transplant. As we look at, we had classified A, B, C, D. Amongst D, you have heart failure class 1, 2, 3, 4. We have another way to subclassify these patients, and these are called Intermax profiles. For patients who are really NYHA class 3, well, depending on how limited they are, they can be, the mildest are classified as Intermax 7 patients. These are relatively, of the sickest patients, they're the least sick. And then those who are imminently about to die get classified in the highest category, which is Intermax 1. The Intermax 1 patients are those who without any intervention would die within minutes to hours. And these are the ones that we address urgently in the hospital with advanced life support technologies like the ECMO, which we'll talk about during this talk. But these classifications, are semantic, but they're important because they allow us to kind of understand the disease and how to address it. Why? Well, if we look at those patients in the less severe Intermax profiles 6 and 7, we know that without a VAD or a transplant, on optimal medical therapy, at 6 months, 78% of those patients will still be alive. And so we have some time to kind of try to figure out what we're going to do with those patients. Instead, if we look at the Intermax 4 patients, who are really the middle of the pack when it comes to severity of illness, they are not the sickest of the sick, and they're not the least sick of the sickest of the sick. They have a significantly different expectancy at 6 months. Only 37% of those patients will be alive 6 months after the start of optimal medical therapy. And that group of patients is really people who we have to try to figure out, how we can prevent their progression to death in a timely fashion. All of these, though, you can see are kind of ticking time bombs going to to move forward. And when you look at it, you look at these INTERMACS 6 and 7 patients, there's still a group of them who are dying. And, clearly we were potentially wrong in their classification. Well, we went and decided to subannualize those patients who were in that least sick of the sickest cohort, the INTERMACS 6 and 7 patients. Those are also known as NYHA class 3B patients. And we're able to actually go in there and potentially tease out, really, there are subphenotypes within all of these patients that impact what their survival is. And because of that, it allows us to, again, go within that group of classification of patients and identify those who are at the highest risk of death and try to intervene before that happens. So if we look at those INTERMACS 6 and 7 patients, at their risk of death at 1 year is very much dependent on how many risk factors they have. And the risk factors we will identify, one is systolic blood pressure. So regardless of how you feel, if your body cannot generate a systolic blood pressure higher than 90 millimeters of mercury, systolic will be the top number when you check your blood pressure, and that's one risk factor. Serum creatinine is another risk factor. Serum creatinine is a blood test marker of your kidney function. The kidneys and the heart share a very close relationship. In fact, we call any dysfunction from the kidney that's related to heart failure cardiorenal syndrome, because the kidney is very much the canary in the coal mine of the body. It is very much dependent on blood flow. 25% of your blood flow of your body is dedicated to going through the kidneys. And because of that, if there's any disruption in your blood flow, your kidneys will start showing signs of dysfunction. And one of those earliest markers is a change in that serum creatinine. Okay. Similarly, your bone marrow that's responsible for creating your blood, well, hemoglobin is a test of the concentration of your blood and how much red blood cells you have. And as you start delivering less blood to the bone marrow, less blood flow to the bone marrow produces less blood cells and your hemoglobin starts going down. So each of these are independent risk factors and they kind of add up together. Finally, there are these medications that we use to treat patients who have heart failure, and specifically these class 3B patients who are INTERMACS 6 or 7. These medications, one of them are called renin-angiotensin antagonists. They function within a system of hormones that regulates the blood flow and regulates the blood pressure, and then another class called beta blockers. If patients are intolerant to these medications, so you start them on these medications and they cannot take them, they get sicker, their blood pressure starts to drop, that also is a bad sign that their heart disease is actually probably worse than their symptoms are showing. And it's so bad that if you only with 3 of these risk factors, a person whose anticipated 6-month survival was supposed to be 75% because they're INTERMACS 6 or 7, actually probably has a 6-month survival of less than 50%, closer to 40%, because of all these other things that are going on. And so this allows us to kind of really understand the patients and figure out when is an appropriate time to intervene. The reason is because our interventions are not benign. They are better than the disease, but they're not perfect. So what are some of our interventions? Well, primary intervention, like we already talked about, is heart transplantation. This heart transplantation provides patients with an option to have good functioning heart and gets rid of their heart failure. Now, we exchange heart failure, which is a disease process that's difficult for us to treat and control, for another disease process, immunosuppression, because this is someone else's heart. So as soon as you put someone else's heart or any organ in a patient, well, their immune system is going to start attacking this. But we're actually very good at controlling the immune system and trying to prevent damage to these organs. There's still lots of room for improvement, and there's a lot. Our lab is doing some research in that arena, but we're a lot better at this than having medicines for preventing heart failure. So what happened? Once we really kind of figured out the immunologic component of it, and that was in the mid 80s, it had to do with a class of medications called calcineurin inhibitors, which is way beyond the scope of this talk today. But heart transplant, lung transplant, kidney transplant, all these things started to take off. And every year, year after year, there's been increased growth of number of people alive with these organs. There's and number of transplants that are done every year. So what are the indications though, right? Hearts aren't just available off the shelf. We have to, they're a commodity. They're something that is not readily available. And so because of that, we have to ration them. So the way we ration them is we make sure that the patients who are getting it don't really have any other options. We call that medically refractory heart failure. So it's heart failure that we've exhausted all of our options, and they are now in the most acute settings, and they fall in those categories of people that are not likely to live 6 months, okay? And so they have medically refractory heart failure, and these are, a lot of technicalities around what that is. They're beyond the scope of this talk, okay? And importantly, they don't have other issues. They don't have any of these contraindications. One of the most important, and this is because of our societal contract with donors and donors' families, we want to make sure that organs are going to people who are most likely to utilize them for the longest. So we don't want to waste this precious gift that's given to us by donors and donors' families, because someone has to die for someone else to live. And so we want to make sure that, first of all, the recipient doesn't have some kind of other illness that's limiting their life expectancy to less than 2 years. We don't want to do a heart transplant in them and then they die of cancer 6 months later. That is a huge failure, and it is a violation of the trust that the community has together around optimizing and being good stewards of these organs. We can transplant people with HIV. HIV is now a chronic problem. It is a very well-controlled problem. People live 40, 50 years with HIV. But those who have uncontrolled HIV, known as AIDS or acquired immune deficiency syndrome, those patients are unlikely to live more than 2 years, and they are not appropriate candidates for heart transplant. Other systemic diseases, lupus, sarcoid, amyloid, lots of other things, irreversible kidney function, irreversible lung function, all of these are contraindications to transplant, absolute contraindications. We cannot do transplant in those settings. There are also some relative contraindications, things that are potentially modifiable problems that, if the patient and their families can address, we can consider transplanting them. The biggest things are going to be tobacco abuse and alcohol abuse. The reason is tobacco abuse after transplant significantly and very quickly accelerates the dysfunction of the new heart. We'll see in a little bit that, the expected median survival of somebody after a heart transplant is 12.5 years. If they're smoking, that drops to less than 3. Okay. Similarly, alcohol abuse really negatively impacts the metabolism of our immunosuppression medication, and also impacts the ability for patients to remember to take their immunosuppression medication appropriately. And so any alcohol abuse or other type of drug abuse really has to be carefully vetted, and you have to make sure that the patient is unlikely to have recidivative abuse. Diabetes is an increased risk factor, and so we're very careful with patients with those. The medications that we use to control the immune system actually are very stressful on the kidneys, and they can very negatively impact the kidneys. And so we want to make sure that if someone's kidney function is not normal, that they have sufficient reserve kidney function and they don't wind up on dialysis after transplant, because dialysis and heart transplant has a significant risk of failure. Psychosocial issues are a big thing. Patients some of these medications will exacerbate underlying psychiatric issues. In particular, they will exacerbate anxiety and medical noncompliance. And medical noncompliance is a big issue. You have to take medications multiple times a day, exactly correctly at the correct time. That requires your mental state to be appropriate to do that. That requires appropriate family and social support so that people can remind you to do that in a timely fashion. Your mental state has to be willing to accept those reminders in a timely fashion. And then it requires a financial ability to get these medications. These medications can be very expensive. And without insurance and without financial wherewithal, you're unable to get the appropriate medication. So it doesn't make sense to put all the effort in to transplant somebody if they don't have the money to pay for the medications, which can be upwards of $25,000 a year to maintain that heart. All these considerations go into it as you're trying to identify if someone's a candidate. But ultimately, patients who do get heart transplants do very well. Median survival, like we talked about, is around 12 years. It is age dependent. The younger you are, the more likely you are to survive. But even those who are in their 70s will have a 8-year benefit, in the median survival, and that's, I think, fantastic. If you remember that we're talking about patients with a less than 40% chance to live 6 months, and we convert it to a 50% chance to live 8 years. And the best thing about this is that over the past many decades, our medications have been getting better, our techniques have been getting better, our monitoring has been getting better. So our expected median survival or our expected half-life continues to increase year after year after year. Those numbers are based on the entire data set. Someone who is transplanted today can reasonably expect a median survival of 15 years or longer. Okay, so what has this resulted in? Well, we're doing more transplants. We're getting better at the transplants. Less patients are dying. Less patients are dying after their transplant. So the number of patients alive with heart transplants is growing year after year after year, which is great, but it also creates obviously a huge both financial and administrative burden on the entire healthcare industry. This is going to continue to grow. This is going to continue to be a problem, and policymakers are going to have to figure out a way to address the issues of access to medications and other things as this group of patients increase. But as people see that there's an increase and improvement in quality of life and access, well, more people want the therapy. And, year after year, the wait lists for these transplants grow. Ultimately, though, unfortunately, as of now, we can't grow these hearts on trees. And so we have to really address getting these hearts from donors, people who die. As these wait lists grow, if our donor pool does not grow, we can't transplant more. And so as a result, people wind up dying on the wait list while they're waiting for these transplants. Just to put things into perspective, okay, heart failure is the leading cause of death in the United States. There's 500,000 patients with heart failure, and we do about 3,100 heart transplants a year. Large centers are considered to perform 50 transplants, and of all donors, about 34% of hearts are used. And so we're going to talk about some of the things that we've done to try to improve that, okay? Just to provide a comparison, liver transplantation is the 12th leading cause of death. Only 27,000 people a year die from liver failure, but more than twice as many liver transplants are done. And it has to do with the access to organs. And so still to this day, organ access is a big limitation for the progress of a transplant. And so you could back up and say, okay, well, looks like we're out. Like we don't have enough. This is part of the COVID supply chain issue. There's not enough hearts to go around. What do we do? And that's initially what we thought, and we were working on other strategies for this. And it still is true. Heart transplant will never make an epidemiologic impact. If we want to prevent 500,000 deaths a year, well, we need 500,000 donors. So that means there's got to be another different group of people dying to save these. And in fact, we have had an increase in donors. This is probably the only silver lining of the opioid epidemic. Over the last 10 years, there has been a massive increase in the number of donors out there, and it has directly to do with drug overdose deaths, and that has continues to increase year after year. As of now, we don't have an end in sight on that, which is devastating. But at the very least, we're in the medical community around transplantation are doing our best to honor and protect the memory of these people. So what does this mean that we're limited by donors? I just said we have more donors than her. Well, donors, our pool of donors is demonstrated by this Venn diagram. If this outer circle is all people who die in a hospital in the United States, well, a subset of those patients will get referred to these organ procurement organizations for evaluation for possible donation of organs. Okay. The organ procurement organizations will evaluate them and make a decision as to whether or not someone is a potential donor. And that potential donor will always be a subset of those who are referred. And, they'll make a mistake. So, there may be some people who are referred that actually could have been potential donors, but the organ procurement organization ruled them out. And there may be some people who weren't referred that, again, could have been potential donors, but they didn't get ruled in. So these are kind of areas that we're missing. Ultimately, of those people who are potential donors, a subset of them will become donors, and then transplant teams will evaluate those, and a subset of those donors will result in transplants. Our goal is to get this inner circle as big as possible, because if we can get this inner circle as big as the size of everyone who's dying, and we do not allow anyone's organs to get wasted, we can really make a huge impact on multiple causes of death, including liver failure and kidney failure. So how are ways we can consider this? Well, historically, we would look at ideal donors, and everybody had to be perfect, and it would go into, ideal recipients, everybody had to be perfect. I started asking the question, well, the donor doesn't need to be ideal. You don't need a perfectly normal heart. You just need a heart that's better than the one you have right now. And if we have a heart that's better than they have right now, maybe the recipient doesn't need to be as perfect either, because we're not taking an ideal heart away from an ideal recipient. Okay. And we saw that, we can look at recipients with increased age or maybe some diabetes or other end organ dysfunction, and provide them with these extended criteria donors. Maybe they're a little bit older. Maybe they have a little bit of coronary artery disease. Maybe their heart function is not exactly normal. And it turns out that they actually do really well. This is data that my lab put together when we were at Duke. And, the patients don't do exactly as well, but they do pretty good. And, we approximate the gold standard donor, standard recipient pairing. And I think we significantly outmatch the alternative, which is, optimum medical therapy. So, the community, because of this data, has started to kind of cloud the issue, and we're starting to think, okay, well, maybe we can take some more of these extended criteria donors and use them with regular recipients as well to try to really improve our epidemiologic impact and the impact of patients overall, how we're making things better. And so as we look at what are some not standard donors, we started thinking, well, maybe we can address issues like infection. Historically, if a donor, for example, had hepatitis C, we wouldn't use that donor for heart transplant because the recipient would definitely get hepatitis C. Well, guess what? About 5-7 years ago, there were medications that were introduced that almost completely cured hepatitis C infection. And so this opened an avenue, and we started doing more and more donors who are hepatitis C positive, essentially deliberately giving our heart failure patients hepatitis C, but then curing them on the back end. We see here that all of them, within a few days of transplant, have high titers of hepatitis C virus in their blood, but with treatment, very quickly, all of them resolve their viremia. And so when we do that, we're able to increase the transplant rate. We were able to more than double transplant rate by utilizing these organs. So you see, we're starting to climb out into that bigger circle, And the great part about that is we're able to do that without impacting survival at all. There is no difference in 1-year outcomes between donors that are hepatitis C positive and donors that are hepatitis C negative that are used for heart transplant. So now, we're looking into potentially HIV. Now, it is illegal in the United States to take an HIV positive donor and put it in an HIV negative recipient. But because of the heart rule, there is the possibility to use HIV positive donors in HIV positive recipients. And we're starting to slowly do that, again, taking another bite in the problem of not having enough donors. Okay. Then we're still not making a huge epidemiologic impact, and we're still not getting access to all of these other organs. And you have to ask the question, why? Well, one of the reasons is geographic availability of organs. Okay. What is the problem? Well, historically, the way we do heart transplant is we procure an organ, we put it on ice, and then we race as fast as we can back to implant that. Why? Well, we know that the time that heart is out of the body, known as the ischemic time, negatively impacts how well that heart is going to work and start back up. So as we start getting further and further out in how long the heart has been outside of the body, preserved on ice, risk of mortality and risk of failure of that transplant increases significantly. So the community, especially heart surgeons, are thinking, well, what are ways that we can address this? Well, we realize that the problem is that keeping a heart cold is not necessarily the best way to prevent metabolic injury, right? It slows down the consumption of nutrients by the heart, but it doesn't stop it. And because we don't stop it, after a period of time, there's just not enough remaining nutrients in this heart that's not getting any blood flow to keep that heart alive. And so because of that, there's significant variability in how fast people get transplanted based on the availability of donor organs. In areas that have a higher population of patients, higher population of donors, easier travel access and all that stuff, will get patients transplanted faster. And areas that are more rural or will have less access will get people transplanted slower. And there are organs, donors, that are potentially good in these far-to-reach places that are being wasted because they can't get matched and connected with a recipient within that 3 to 4 hour window. Okay, that time period of the heart being out of the body for travel, the physical limitations of travel, negatively impacts things. So what did we do? Well, we decided it makes sense to do perfusion. Let's treat the heart like the body does. We'll deliver blood to the heart. We will provide oxygen. We'll provide glucose, and we'll treat the heart. And so and this is research that we started when I was at Duke, and this is now very publicly done. And so we go in, we procure the hearts, and the heart is placed on a system. This system is made by a company called Transmedics, and it's the organ care system. We perfuse the heart with blood. We can monitor blood pressure, heart rate, and then blood flow in the coronary arteries, as well as toxic metabolites. Lactic acid is a toxic metabolite, and we can trend it and see, and it's a marker for us. Is the heart doing well, or is it not doing well? And so by following the lactic acid, we tend to see how are things going? And so now we've overcome one of the other burdens, which is geographic access to this, and we're able to get rid of the ischemic time as a concern and have more better distribution of the organs. But we should stop and ask ourselves, well, what does it take to be a donor? Well, obviously, to be a donor, you have to be dead, right? In the United States, there's a dead donor rule. What that means is that the donation procedure cannot cause the death of the patient. That would be considered murder, okay? So people can donate a kidney because that doesn't result in their death. People can donate a piece of their liver because that doesn't result in their death. But I can't tomorrow say I'm going to donate my heart to somebody, because the procedure itself to donate that heart results in my death, and I have to be dead before somebody can remove my heart. I have to be dead before somebody can remove my lung or my liver in total, or take both of my kidneys. And so then it begs the question, what does it mean to be dead? Well, there are two classifications of death in the United States. There's brain death, okay? And what does that mean? Well, brain death is the permanent loss of function of the entire brain. Doesn't mean that the heart has stopped or the lungs have stopped. The heart will still beat, the lungs work, because there's machines that are supporting that. Those machines are there just to keep the other organs alive, but the brain has been certified as dead. There's tests that we do, physical exam tests that demonstrate the brain is dead, and then there are imaging tests that we can do. In particular, the most sensitive test we can do is a blood flow test. So you see here, this is radioactive contrast that's instilled in the blood of the patient, and then a camera measures how much radioactive activity is happening in the brain. This is a healthy, normal person. There's a lot of activity within that brain. And in fact, we can tell the difference between someone who's in a coma or a persistent vegetative state. They're not brain dead. They still have blood flow to the brain. They may not be awake. They may not be able to interact. They may never wake up, but they do not meet the very strict criteria of brain death, versus brain death, which is the complete absence of blood flow in the brain and the permanent loss of complete function of the brain that's outside of the spinal cord. So you may still have intact reflexes, you may have other things, but you are not ever going to recover brain function, and you're technically considered brain dead. The interesting thing about brain death is that it's a legal definition, and once this has been diagnosed by a physician, a death certificate is issued, and it is impossible to reverse this. No one is, and all the things that a normal person has, like the ability to decide what happens to them and all that stuff, technically goes away because they're no longer a person. That being said, we still very much respect people's pre-mortem wishes, and as a rule in this country. The other way that you can die in the United States is circulatory death. And circulatory death is relatively self-explanatory. It is the stopping of blood flow to the body, okay? So how do we address these transplants? So if someone is brain dead, their heart is still beating, we can, in a controlled fashion, take them to the operating room, open their chest, examine their heart, look at how things are going, make sure the heart is working, then deliver a medicine to the heart to cool it down and turn it off so it's not using too much energy, and remove it, put it on ice or put it on a machine, and then bring it back and put it in the recipient. But up until recently, we were not touching circulatory death donors. Why? Because again, according to the dead donor rule, donation cannot result in the death of a patient. So circulatory death donors, while they would donate kidneys and livers and lungs and other things, could not donate hearts, because you were unable to operate on these patients and remove their organs until their blood flow had stopped. So you take this person to the operating room after their blood flow stops, you open their chest, and the heart is not moving. It's impossible for you to assess if that heart is going to start moving after you use it, or if it's been irreversibly injured. And so until we had the ability to use the OCS device to do this, we did not do circulatory death donation transplants. Ultimately, though, a few years ago, we decided that we're going to start looking at circulatory death donors, and there was 5 centers enrolling. I started this process when I was at Duke. We continued it here when I came to Emory, and we were both Duke and Emory were centers in this, and we were able to go in. We got hearts, and we were able to resuscitate them. We put them on that TransMedics machine. We evaluated how well they worked, and we were able to do transplants. We predicted that if we were to be able to do that, we could potentially increase access to transplantation by 1/3, and it actually bared fruit. This was the paper we just published this year on this in New England Journal of Medicine. This was us from all these 5 different centers, and we were able to show that, hey, not only can we do this, not only can we use these organs, but in fact, these organs are just as good as the brain dead donors. They're not, and they're statistically non-inferior as brain dead donors. And so this has opened a huge avenue of potential of access to potential donors. I think we're at 50 minutes. Dr. Vazirga, do you want me to stop here, or do we want to for questions, or should we keep going?
No, please keep going.
I'm going. Okay. All right. So what do we do, though, for the patient who can't wait for the heart transplant or can't wait to get their other, they're too sick, or an organ's not becoming available in a timely fashion? Well, there's got to be a solution for that. And in fact, for the longest time, a lot of old white men have been trying to solve this problem. The pursuit of a better artificial heart, has been a goal for a lot of people for a very long time. This is Dr. Denton Cooley, you see here. This is Dr. DeBakey and Dr. DeVries, and this is actually one of our original teams at Duke, who are all kind of working on these things, a solution for the heart when transplant's not an option. Really, some of the first patents on ways to help the heart come from the 1940s, when we really had no option really even to do heart surgery. Heart surgery wasn't invented yet. This was entirely theoretical. We did not have a heart-lung machine. There was no open heart surgery, but these were started to have pump solutions for this. Ultimately, a lot of activity happened in the 1950s and 1960s, most of it in Texas. It's very much having to do with the Cold War, very much having to do with the spoils of the space program and the space race. These were monies that were allocated to identify a better heart than the hearts that we have through the NIH Artificial Heart Program. And these culminated in the first implant of an artificial heart by Dr. Domingo Lyotta and Dr. Denton Cooley in 1969 in Houston. And this is that first patient. That patient, 12 hours after surgery, as you heard, was awake and talking, and you heard some noise in the background. That noise in the background, you'll see in a second, is this device right here.
Mm.
Yeah, there's no sound monitor. You didn't enable the sound.
Oh, you guys can't hear the sound?
No.
No, because perhaps you didn't check on the sound.
Okay, well, I apologize, but there's let me see if I can. Yeah, it's not letting me change that now. But there, here, I'm going to stop the share and try it again. Hold on one sec.
Yeah, you have to check 2 parts, sound and video.
Let me go.
Yeah.
Here we go.
You know your operation's over? Yeah, you had your operation about 12 hours ago. That's why your chest hurts. What?
So this machine that's the size of two big washing machines is the pneumatic pump and drive system for the total artificial heart that was created by these folks and implanted. And this patient was able to live 3 days without a heart, ultimately succumb to bleeding and infection and died. But this was really the burgeoning first step in our pursuit of left ventricular assist devices and total artificial hearts. Really, no one else got a significant implant of a total artificial heart until 1982. Bill DeVries implanted Barney Clark, who was a dentist, and was able to support him with this device known as the Jarvik 7 for 112 days while he was waiting for transplant. Unfortunately, Dr. Clark also succumbed to infection and died. But these pioneers resulted in the advent of the new pumps that we have right now and progression of access and availability to LVADs that we use today. This is one of the first commercially used LVADs that we have. This is called the HeartMate XVE. This was a electronically driven pump that sucked blood out of the left ventricle and delivered it into the aorta. It was implanted and had a power cord drive line that came out of the body to do that. And this was the centerpiece of a landmark clinical trial known as REMATCH. So in the early 2000s, patients who had the NYHA class 4 heart failure were randomized to either medical therapy or treatment with this device. And those patients, as we've demonstrated time and time again, had 40%, those who got medical therapy had 40% 6-month survival. Those who got this, mid-generation pump had 60% 6-month survival. And were able, they're able to survive up to 2 months, 2 years with the pump. And this was a huge change. This started a spur of surgical treatment for heart failure, as well as therapies around how to develop new and better pumps. Very quickly, these therapies were adopted, and the number of LVADs implanted in the United States started to grow exponentially. And we finally had a potential epidemiologic impact, right? Because we could build and manufacture these devices. And so we've continued to iterate on them, and we continued to start having improved survival. By the early 2010s, we were really seeing a significant survival with the newest generation of pumps of 70% survival or longer at 2 years, which is completely different than we were seeing with the first generation of pumps and with medical management. Still a big gap, though. There's the upper right-hand corner of the survival curve of those who we have failed as a specialty. And so what happens to those patients? Well, these devices have their limitations. Their biggest limitations are around infection because they have a power cord coming out of them. Managing power transcutaneously is not really, even today, a possibility. We have to deliver power to these pumps. The pumps, this generation of pumps, not the most current generation, but would have debris that would form on them. They would fail. They would have clots that would get sent to the brain. They would have other issues around compatibility with blood and compatibility with the tissues of the heart. And what we learned is that, LVAD therapy dramatically improves survival, but LVAD therapy is imperfect. There are significant complications around LVAD therapy. And, unfortunately, it lacks some of the criteria that we would define as the perfect pump happening. No driveline to get infected, no, good blood compatibility, good support, etc. And really, unfortunately, this is the only thing that does that, right? This is what God gave us. This is our original heart. But, we continue to innovate and iterate to make things better. The newest generation pumps that we have are electrically driven. They're much smaller. They fit in the palm of the hand as opposed to being huge refrigerators. Okay, they run continuous flow using an impeller that's fully magnetically levitated. There's no bearings. So there's no area of heat generation. There's no area of mechanical wear. The pumps have large, wide blood passage areas. They have specific programming that allows it to vary the speed of the rotor to allow washing of the rotor. And we see that with these pumps, we continue to improve survival and continue to improve the safety profile of these. In fact, compared to the previous generation pump, the HeartMate 2, our current generation pump, the HeartMate 3, has a tenfold decrease in complication rates, which is fantastic. Not only that, but these patients all do well. If you remember, all of these patients we were implanting had that New York Heart Association class 3 or 4 level of symptoms. Well, within 12 months, a vast majority of those patients dropped to level 1 or 2. And so really a significant improvement in their symptoms and problems, okay? They're able to walk more. They walk more, they walk faster, they walk more comfortably, they have significant improvement in quality of life, and they have significant improvement in all aspects of their quality of life, except financial. These therapies are expensive. One pump costs $120,000. In general, every patient who we're doing this, we're spending close to $1 million per patient to get them there. So while everything else improves, their financial status all improves negatively. Still, we have lots of room for improvement. There are still complications that happen, and the longer you have the pumps, the more likely you are to have the complications. I'm going to fast forward through some of these. One of the biggest issues we still have, though, is that, if you remember, I said the heart is 2 pumps working in parallel and in series circuits. And, an LVAD only really addresses one of those circuits. Sometimes you need to have both. You have failure of both sides. And, we had this problem at Duke many times. And so we, my lab and I decided to address this by just, making our own device. We've been using the current off-the-shelf HeartMate 3. We decided we're going to take patients to the operating room. And here you see patients' heads over here. This is their heart. And we've cut the heart in half. And we go and remove pieces of it. And we actually put 2 of these HeartMate 3 pumps in parallel next to each other and provide these patients with support that is functioning like a total artificial heart. And is a novel way to be able to get patients alive out of the hospital and potentially to be able to live for many, many years. And these patients have no heart, they have no EKG, they have no pulse, but they're alive, and it's kind of a freaky thing. I'm going to try to do the lungs very quickly. We'll spend a few minutes so that we have at least 20 minutes or so to talk about questions. So what about lungs? Well, the 1960s was a great time. 1967 was the first heart transplant. The first lung transplant was reported in 1963. It was done by Dr. James Hardy in Jackson, Mississippi. The interesting thing is actually Dr. James Hardy did, people don't know this, but Dr. James Hardy did actually the first heart transplant ever. Dr. Barnard did the first human-to-human heart transplant, but Dr. Hardy in Jackson, Mississippi did a primate to human heart transplant in 1963 as well. At the same time, in 1963, he did the first lung transplant. And I would recommend for anybody to go and actually pull this article. It is a fascinating case report, and it's amazing the things that were happening in the 1960s in the United States. This patient, the recipient, was a prisoner in the state, and he was condemned to death, and he had lung cancer. And Dr. Hardy wanted to be able to try his technique of lung transplantation, and so he approached the state, and they approached this prisoner, and they offered to convert his death sentence to a life in prison sentence if he was willing to participate as a research participant here, which violates many, many current rules of ethics, including doing research in in vulnerable populations, for incentivizing research, participation, and all these things. But this courageous person got a lung transplant, ultimately died 18 days later of kidney failure, but he started a revolution of the possibility of being able to do a lung transplant. And lung transplants, just like heart transplants, have been growing year after year. That being said, we still have a huge gap here. It's the fourth leading cause of death. There's 124,000 people who die of lung failure every year. This is not cancer, this is lung failure of various different causes. And really only 2,000 lung transplants are done a year. And we're using less than 17% of donors for lung transplant. But so what about lung transplant? How do we get people with lung failure to lung transplant? Well, their therapies for lung failure are a continuum, including artificial ventilation by putting a tube in someone's mouth is kind of our first line therapy. Okay. But, until we had other more advanced therapies, really doing lung transplant in the most sick patients was not really a possibility. Ultimately, the lungs are a beautiful organ in that they are very likely to recover function should you support patients long enough and prevent other things from happening to those patients. And so really the concept of extracorporeal circulation or extracorporeal membrane oxygenation was a disruptive technology when it was first formed. There were three groups working on it simultaneously. Ted Koblow's group at the NIH, Ron Hill's group at UCSF, and Bob Bartlett's group at the University of Michigan. And in the 1970s, they finally kind of cracked it and initially had some very good initial survivors. But really, it didn't really get adopted and used more widely until the early 2000s. And, part of it had to do with the technology and, the dark ages. It was the dark ages. The artificial lung or the membrane oxygenator is the key to supporting patients who have lung failure. Well, the original versions of this is the original patent by Dr. Bramson for the Bramson oxygenator, were massive devices. So this is that device. It's the size of a washing machine. You can see it relative. This is Dr. Bramson here, relative to the people looking at it. And you can imagine how much blood it takes to prime such a device. The first patient who was supported on this just was supported for 3 days in that time period, got every day here, got 10 units of blood, almost 10 units, 6 units of plasma, 13 units of platelets, and had massive blood trauma while this was all happening to them. And so the technology was not perfect, yet that person survived, and it started a chain reaction of things. So this immediately started some clinical trials of patients with lung shock. Back then, lung shock was 100% mortality thing, and they supported patients with ECMO with various things. And, in these studies, they had 2 survivors, and they viewed that as a sign of, okay, we should continue, as a mandate of we should continue doing things. They progressed. They tried it again. In this scenario, they had 75 patients. Only 8 lived, but they kept trying. And they kept pushing, and the technology slowly got better. And, all of a sudden, in the mid-2000s, in the early 2000s, patients are starting to maybe do a little bit better with support, getting ECMO versus conventional therapy, resulting in more survival, but still not perfect. Why? Well, because our technology hadn't been perfected yet. This is in the early 2000s, this is what the oxygenator looked like, about the size of a Coke can, significantly miniaturized, but not perfect. You may notice that there's foam coming out of it. The membranes were still, unfortunately, too porous to be able to be used. So it's a unique problem, right? You have to create a membrane like the lung that is impermeable to liquid, to liquid, but permeable to gas. That's a hard thing to do and to maintain that. So after about 18 hours, all of these things that were had that property would it would get dissolved, would lose the impermeability to liquid, and would start foaming liquid out of the bottom. And so there was plasma leakage. It made people more sick. There was failure of the oxygenators. And it wasn't until the advent of a technology known as PMP, or polyethylene methyl, I don't remember the last P, coating that prevented that leakage. And we were able to actually now use these oxygenators, still the size of about a Coke can, long term, with huge improvement. Now, you need a little bit of luck, though. These PMP coated oxygenators came just before the H1N1 epidemic of 2009. And that timing was perfect because you had a pandemic, a flu pandemic, people were dying, and they were young people. Up until then, it was older people who were dying in the flu season. And so people were desperate to sign up. So they went back and revisited ECMO. And really, that's when they started to see that, hey, we can actually support these patients. And there was a huge uptick after that of utilization and research around ECMO, and ECMO is now the gold standard for supporting patients. If you don't survive ECMO, then we start thinking, or if you don't improve despite surviving ECMO, then we start thinking about transplant. And so what do we do for transplant? Well, we try to transplant these patients, but we, again, are limited by donors, and we're only using about 17% of these donors. So how do we expand the donor pool? Well, we try through education to try to really be aggressive in how we manage the donors. The lungs take a lot of injury from the body. They are very susceptible to minor changes and mismanagement, especially in the peri-death area. Okay, the circulatory death issue is also a big issue around lungs. Not a lot of lungs are being used from circulatory death donors because the circulatory death process puts a lot of stress on the lungs and potentially damages them. And so we had to figure out ways to make these lungs better. And one of those ways is, like we talked about, fixing the dissolution, but then using technology to evaluate these lungs and repair injuries that's happened to them in the brain death environment or the circulatory death environment. And this was interesting because it actually made popular news when we started doing this in 2009. This is something, again, we started while I was at Duke, and we've continued here at Emory and doing active research on it and using it clinically. But we decided we're going to take these lungs out of the body and, again, perfuse them and try to make them better. So we take these lungs, and you see these lungs, they look beat up, they're not great and all that stuff. And through a period of time of perfusion and treatment, we're able to take lungs that are not looking so well and may not work that well and resuscitate them and rehabilitate them and get them to a point that they can be used for transplant. We can monitor all different types of data on the lungs, try to figure out how they're responding to the therapy. We are able to monitor them with x-rays. And ultimately, and this is the most important thing, we examine them. We can see them, and you see how beautiful, nice, and fluffy these lungs look. They've been rebuilt after a period of time. And still, the backside of this particular lung is not 100% there yet, but we have time to support them and get them to a point where now we can use those lungs for transplant. So EVLP, or ex vivo lung perfusion, is the name of this technology. And, it has increased utilization by 54%, okay? And it has allowed for a significant improvement in access to lung transplant. I just want to end with a quick case description of a particularly difficult case, and I think it'd be an interesting case of some of the extreme things we're able to do nowadays. So this is a patient, 30-year-old male with cystic fibrosis. He had his lungs were infected with this bacteria known as Burkholderia multivirans. This is a particularly virulent bacteria. It used to be thought of as part of a Pseudomonas group, but it's its own species. And this particular Burkholderia was multi-drug resistant. So it had developed resistance to many different classes of drugs, and so it was a particularly virulent stuff. This patient decompensated, and they were sick, and they were about to die. And so we had to put them on ECMO to be able to provide oxygen to their blood and keep them alive. This is what their chest x-ray looked like. This is the cannula going through their vein into their heart, providing blood flow through the ECMO. And then this is their lungs. Their lungs are completely replaced by abscesses and infection that from the Burkholderia. And because of that, their bloodstream is infected, and we cannot transplant them, because if we shut down their immune system to do the transplant and setting of active infection is going to take over their body, and we don't know, they're going to die. So we decided to do something crazy. We said, well, the lungs are infected. Let's take out the lungs. So, but that means it's easier said than done, because there's blood flow through the lungs. You got to redirect things and all that stuff. So what did we do? We took the patient to the operating room. We opened their chest. We put them on the heart-lung machine, took out their lungs, and then said, now let's solve the problem of blood flow. Well, this is the right side of the heart, or the right ventricle. Blood coming from the right side of the heart usually goes out the pulmonary arteries to the lungs. Well, now there's no lung. And then it comes back through the pulmonary veins into the left atrium, to the left ventricle, and out the aorta. Well, again, there's no lung. So we decided, well, let's take the pulmonary arteries and connect them directly to the pulmonary veins. So now the blood is ejecting from the right ventricle, going into the left atrium and going into the left ventricle. So that solves the circulation problem, but this blood doesn't have enough oxygen. So we decided to use ECMO to help with that. And we sucked the blood before it made it to the heart out of the body. We put oxygen in it. We took the carbon dioxide out of it. We delivered it to the heart with carbon dioxide removed, with oxygen in, nice red blood, and then use the heart to pump it around. And we were able to support this patient. This is here you see their x-ray. They have no lungs. These are all the cannulas inside their chest, and they are alive. They're alive with no lungs. We supported this young man for 6 days without any lungs. Ultimately, their infection was cured. We were able to find lungs to transplant them. And on day 7, after that procedure, we transplanted new lungs. This is the x-ray after the transplant, and this is their x-ray 1 month after transplant, and they did very, very well. So, this is a picture I took in Maimonides Medical Center in 2011. I was there procuring a heart, and this plaque was there commemorating Adrian Kantrowitz. So Christian Barnard did the first human-to-human heart transplant in the world. The first human-to-human heart transplant in the United States was done a couple of years later by Adrian Kantrowitz. And this is what he said. And this was done at Maimonides Medical Center in New York. And this plaque was commemorating that. And this is what Adrian Kantrowitz said at that time. And I think it resonates still today. He says, all these years later, I can still see it clearly. It was an unforgettable sight. We'd taken the old heart, and we needed to move damn fast to fill that huge hole with a new heart. No wonder they were frightened of us then. No wonder they thought we were out of our minds. These people were pioneers and leaders, and they, through significant personal risk and expense, have impacted everybody in the world. I feel the way Adrian Kantrowitz feels every time I do a heart transplant or a lung transplant, or sometimes when we do, in particular, when we do combined heart-lung transplants, because I go in there and I remove both, and I'm just looking at this huge empty abyss, and I say, well, I better not screw this up. I hope we can get things going and get this patient to live. Ultimately, I want to leave you with this. Everybody who's on this call has loved ones, has family members, and I hope everybody stays healthy and is alive for hundreds of years. Okay, but just remember, when bad things happen, one of two things will happen to your organs. They'll either go in the trash, or they'll go into this young little girl or someone like her. And so think about organ donation. Talk to your families about organ donation. You're not, just because you put it on your driver's license or something does not mean you're an organ donor until you talk to your family, because you don't want your family to not know what your wishes are and be fighting them in the last minute. I'm going to stop there, and we'll be happy to take questions. Thank you, everybody, for your attention and time.